We didn't do this slot last year, but I think, well, you may feel that there's a need and you can feed back at the end of the day, but that picture on the bottom right is possibly a little bit daunting. You know, when you're having surgery, the advantage is usually you're fast asleep, so you don't see all the technology, all the bells and whistles and the stapler, thank goodness. I mean, you know, you don't get to see all that, but of course in endoscopy, you're either wide awake or just slightly asleep, and so you see all this technology and it can be a bit complicated. And added to that, all the terminology that we use, it isn't really to confuse you, but it can be quite difficult. So we'll try and clarify some issues, and if I don't cover it now, then we can cover it at lunchtime over a sandwich. Always good to talk about colonoscopy over a sandwich. You can't embarrass me, okay, so you can talk to me about anything. So you've already heard this, and it's not because we're boastful, but I am going to reiterate it. We are very, very proud. I'm the clinical lead of an OMED Centre of Excellence for Endoscopy. There is one in the UK, and you're in it here. They're open today, okay, they're scoping patients today down in our unit. And it's really recognition of the research into clinical matters, training of endoscopists from around the country and around the world, and research into endoscopy. And we couldn't do any of that without you. Okay, so our research and training is meaningless without the benefit of having patients who are willing to come here. This is some of the team, okay, we're very, very keen on having a good team in endoscopy. The administrator on the right-hand side, one of our porters who's been here longer than I think all of us put together, in the middle, Huey there, Cynthia, one of our senior sisters, and a number of other endoscopy nurses in the bottom here. And this photograph, as I say, was taken actually this morning, okay? They're smiling, genuinely. I didn't say, smile, I'm taking a picture. They smile, okay? They may not smile every single time you see them because we are busy, but we're busy because there's a lot of work to do and we're popular. But we're very, very happy to see you and to welcome you in the endoscopy unit. So what is endoscopy? Well, Crohn's and colitis affects anywhere, particularly Crohn's, from the mouth right down to the bottom. Not necessarily in every patient, but it can affect all of those areas. And so endoscopy is also used in other parts of the body in different forms, but endoscopy refers to any procedure that looks at the gut from the inside. And there are lots of different types of endoscopy, and I'm not going to go through them all, you'll be glad to know, but they all have different names. These are just some of them. You could add in pouchoscopy, lots of different ERCP, all sorts of different things. And really the name, the clue is in the bit of the body that we're looking at. We don't do horse endoscopy here in the Wolfson unit. It's obviously something that perhaps we could look at doing in the future, but we're busy enough at the moment. But that's one type of endoscopy we don't do. So what about gastroscopy? It's also known as endoscopy, OGD, which is esophago-gastro-duodenoscopy, upper GI endoscopy. It's all the same thing. And basically, we can look at your mouth. We see the vocal cords, but we go past those so that we don't choke you. We go through the esophagus or the gullet, into the stomach, and down into the duodenum. And many patients, certainly maybe not with colitis, but with Crohn's disease, may have a gastroscopy at some point. You can feel a bit windy, as you can see in this picture here, but generally it's a very well-tolerated procedure. You have to fast, which is probably one of the most the nuisance things of it, so you have to have an empty stomach, obviously. And we usually do it with just a spray in the back of the mouth or light sedation, and you have to bite on that guard. That's really to protect your teeth and our endoscopes, which are very, very expensive bits of kit. And in the red there, those are really what I would say the side effects are. You can gag a lot and retch, and it can be a little bit uncomfortable. You feel like you've drunk a pint of Coca-Cola or something because you do fill up with wind. But it's usually very well tolerated. What about looking at the bowel from the other end? I have a wide collection of amusing postcards. If you see any of these, you can send them to me because I do like these. This polar bear's got Polaroids. Anyway, what do we see at colonoscopy? Well, we go in backwards. So we often talk about getting to the end of the procedure or the beginning of the procedure, but we're looking at the colon, which starts over here. So the small bowel or ileum meets the colon at this area here, and then it goes round in a in a diagrammatic shape here, which isn't, as you'll see in a moment, isn't necessarily what it looks like down to the rectum. But of course we go in backwards, if you like. We're very good at going in backwards, but we do need light, and that's some normal bowel mucosa, beautiful blood vessels. It's no wonder endoscopy is such fun, you know, beautiful pictures that we see. That's the end of our colonoscopy, or the beginning of your colon in the cecum, and that's the small bowel, which is also very, very beautiful, with all the little villi that sit there and absorb your food. What about colonoscopy? Well, many of you will know you do have to. This is much more of a involved procedure. It does involve dietary restriction. You have to stop certain medications that might prevent the bowel from cleaning out adequately. You have to take those nasty laxatives, usually a combination of something to push the stool out and to suck the water out to give you some diarrhea. We're sorry about that. There's a very good Billy Connolly sketch on YouTube if you're ever feeling you want to be cheered up while you're taking your bowel preparation. We usually offer sedation for the procedure. We try to achieve painless colonoscopy. I really genuinely mean that. And it is achievable, but most people find it a little bit embarrassing and certainly perhaps a bit uncomfortable. It shouldn't be worse than that, and therefore we usually offer sedation. But it's conscious sedation, so you're able to talk to us during the procedure. We can use Enteroscopy, which is a bit like pregnant women have through labour, gas and air. That's great because you're back to normal straight away. You can drive yourself home if you wish. And very rarely we do colonoscopy under general anaesthetic, but we don't offer that routinely. We just don't have the capability, or in fact it's not necessary to do that. And the procedure takes about 30 minutes, 30 to 45 minutes. It's one of the reasons why in the waiting room you see lots of people come and go at different periods, and you might feel like you've forgotten. And that's because colonoscopy really can take 20 minutes or it can take an hour. And it's very, very difficult for us to predict that. So that's why sometimes you're kept waiting, because patients ahead of you have taken a little bit longer. The main disadvantages, well, it is the bowel preparation, but we obviously need to see what we're doing. And again, you can feel quite windy afterwards, but we do use something called carbon dioxide here rather than air to inflate the bowel, which makes you less windy. And as we go round some of the bends, it can be uncomfortable. As I mentioned, that's a very simple diagram of the bowel. In reality, that's just the position that you'd be lying in. In reality, this is what happens. The bowel actually loops up inside, and as we're inflating it and pushing the tube in, it can twist and turn in different ways. And many of you who've had colonoscopy will see that we have fantastic imaging equipment here, which shows us how the tube is looping inside. A flexible sigmoidoscopy just examines the left side of the bowel usually. That's often very useful both at diagnosis and assessment, just to have a relatively quick look inside to see what's going on. And we can take some samples, some biopsies. You don't need any dietary restriction, and you usually would just have an enema either at home or in the department. And we don't usually need sedation for that, and it's a much, much quicker procedure, but it doesn't examine the full bowel, obviously. The same disadvantages. Enteroscopy is really, as has already been alluded to, one of the new things in endoscopy. And again, one of my colleagues, who I'll show you in a moment, is leading the way here. And it's because of those metres and metres of small bowel, which previously we couldn't see, and actually is the main site of Crohn's disease in many patients. And we couldn't actually visualise it, but now we can. We can, in some selected patients, use something called capsule endoscopy, or we can push in various ways an endoscope through. So this is capsule endoscopy. You can see the capsule up here. It's about the size of a large jelly baby, and you swallow it, and it gives these fantastic images. Whoa, gosh, sorry. These fantastic images, I'll just go back, of the small bowel as it travels through, and you wear a little sort of Walkman on your belt, and it collects the images through the day over about 6 hours. If we actually have to get to an area, for example, to deliver some treatment, stretching up the bowel we've heard about, Chris Fraser, who's on the right there, and that was one of his registrars, Ed Despot, just showing the double balloon colonoscope here, or endoscope I should say. They can now actually reach parts of the small bowel that we could never really reach other than with our surgical colleagues previously. So this is a fantastic resource that we have here. It's very, we are one of only a handful of centres in the UK, so the waiting list, I'm afraid, it is quite long, but we do have that facility here for a select group of patients who really need that. So what about, how do we actually use endoscopy in Crohn's and colitis? Well, we use it at diagnosis, which means that the majority of people who, well, certainly everybody who has Crohn's or colitis will come to endoscopy at some point. We use it to assess how your disease is going, how you're responding to treatment, for example. We can manage your disease in some ways. We can deliver therapy. And then particularly for patients with very long-standing colitis, we can what we call survey it. And I'll come on to explain that in a moment. So these are just some of the images that we may see. That on the top right is somebody's gullet, their esophagus, their colon in the bottom three pictures. That's quite an active colitis. You can see those beautiful blood vessels that I saw earlier. They're completely gone because there's ulceration and bleeding. That's again some deep ulcers in Crohn's disease. These beautiful little, it's like the coral reef, they're little polyps of actually a healing bowel. So that might look abnormal, but actually that's a healing bowel and nothing to worry about. That's a normal small bowel, and that's a narrowing, one of these strictures that you heard people talk about earlier. And we can stretch these strictures up. So there's a narrowing. You can imagine it's difficult for food and stool to pass through a narrowing like that. These can occur just in Crohn's disease or after an operation at the join. You can pass a thin balloon. I always liken it to a Bic biro. You put a Bic biro through, and then the outside of the catheter has a balloon in it, which stretches up that narrowing and opens it up, as you can see. And of course, there are risks to these procedures, but it's safer often than surgery, and surgery is obviously there and available if you are unfortunate to have a complication. I'll skip over this. This was a video, but I think lunch, it might put you off your lunch, so we'll carry on. So disease surveillance, what do we mean by that? Well, we don't, cancer has already been mentioned. If you have colitis for a long period of time, there is an increased risk of cancer in your colon. And we can't prevent that from happening completely, we don't think, at the moment, other than by removing the whole colon. And that's obviously not necessary in the vast majority of patients. However, what we do once you've had colitis for about 10 years, is we start surveying the bowel. And that means coming to the department to have a colonoscopy, either once a year or 3 years or 5 years, depending on what we find. We use this special blue dye that you can see in those bottom pictures, and we look for abnormalities. And we may see polyps, a bit like in the previous picture, that don't need to be removed, or we may see early benign growths that may develop into cancer that we can remove and prevent that particular area from becoming cancerous. So we can prevent cancer from progressing or developing from small abnormalities. What do our patients think? I mean, we mentioned about research and why it's important, and I've just brought this in because Matt Rutter, who was here when I was here as a research fellow back in 2004, 2006, looked at what you yourselves, you thought about coming back and forth for surveillance colonoscopy. And this is just to show you, this is published, so this is just really to reassure you that if you are ever asked to take part in research, we do use it for the benefit of you and other patients. So we asked patients questions about how they felt about coming for surveillance. And I'm pleased to see that the vast, vast majority of patients do feel reassured. About 84% of our patients are worried about cancer. But actually, again, importantly, a very small number think that they're more anxious because they're coming for surveillance. And so it's very important for us and our inflammatory bowel disease nurses and our endoscopy nurses to understand that you may feel more anxious rather than being reassured. So research is very, very important. Again, what other areas of research are we involved with in endoscopy? I'm particularly interested in the safety and the use of teams and checklists in endoscopy. You can see us performing some checks just before a procedure here. We're looking at how well the team functions right from when you're met by the administrator all the way through the patient pathway. And that's something that we're very interested in here, but just to reassure you, it is part of, you don't need to listen to me, JAG there, which is a nationwide professional organisation that looks at endoscopy units across the country, accredits units, and says whether they meet the quality standards, which are all patient-driven, about the patient experience, patient satisfaction, and the patient pathway. And we are, of course, JAG accredited. If we look at patient satisfaction, and we have to do patient satisfaction questionnaires from time to time, so you may be asked to do that. We have to do it twice a year, actually. And most patients, we're pleased to hear in endoscopy, have a very, very good experience. But there are common niggles, and you can beat me about these at lunchtime, I don't mind. Communication, we don't always get right. That's, even with our best intentions, we don't always get it right. There's now an NHS initiative that patients only of the same sex can wait together once you're changed. So that's why in endoscopy units now, if you're having a procedure where you have to get changed, you cannot wait with anybody, even if it's a relative of the opposite sex, for privacy and dignity. So that's not our rule, that's an NHS directive. Waiting times in the department, perhaps I've explained a little bit about why that might be, because we can't always predict how quickly procedures are going to go, and making contact with us. So we're aware of these issues, we're constantly trying to improve, and if you have any feedback, we're always very, very happy to receive it to try and improve the patient experience. Just lastly, we've heard already that we're a centre of excellence. Research and training is really, really important. Okay, so we have lots of trainees. And what do we mean by a trainee? It's not a medical student coming to have a go. We don't have medical students doing endoscopy. We have qualified doctors who are specialising either in GI disease or in endoscopy in particular, some of whom come from other hospitals, some of whom come from other countries, really because we are a centre of excellence. Anybody who is learning a particular procedure, and it may be another consultant who's coming to see some of the new procedures you've heard about, is always supervised by a senior member of staff from our unit. So it's very, very safe. But it is very, very important so that we can improve things, and there are lots of advantages to you as patients for us being a teaching and training centre. We're very lucky, we have state-of-the-art kit to make endoscopy easier, with excellent high-definition screens and so on to pick up abnormalities that perhaps wouldn't be spotted elsewhere with other kit. We have specialists working with other specialists. You've seen this. I'm a gastroenterologist, but my focus is endoscopy. And so all of us are specialists in GI disease, but we have our own niche area as well, and we communicate very, very easily together. And we produce research that changes outcomes and patient management. And that really is because we are all very committed to providing excellent patient experience and care. And my very last slide, many of you come to endoscopy wonder why we give you these terrible paper pants to wear. Well, it's obviously because we prefer that visible panty line rather than the alternative. Thank you very much.